Okay, well, I don't see anyone new coming in to the waiting room, but I'll keep watching that.
Okay.
So welcome. This is our fourth in this five session series for coding for value-based care. And today we're going to be talking about ADHD and asthma. And again, our speaker is Shelley Sulzberger with Coding and Compliance Initiative. I'll hand it over to you, Shelley.
Thank you. So before we start, you guys, I just want to say thank you so much for completing the evaluation on the last series. There were several good comments, questions, thoughts. So I want to hit the three main things I pulled away from the comments. So someone asked, really like, why do we need to understand HCC codes and how do they actually work? So I'm going to just give, like 100,000 foot level because we could talk about that really in depth. But so understanding them is really important because they directly impact your reimbursement and value-based care. We may not see them on the front end when we're submitting the claims, but there is that back end, when you're tied to that ACO for that reimbursement, what I will call it like bonus money. And it truly outlines and ensures that we're telling the story about that patient's true disease burden. We're reflecting that through our diagnosis codes. So not only does it impact reimbursement, it impacts how we're describing the complexity of the patients you take care of. It impacts like the quality metrics with that shared savings. And then like how it works is really, it starts with your front desk capturing the appropriate demographics and all of that information, and then moves to our providers documenting those chronic conditions. So they're documented clearly, concisely, and to the highest level of specificity. In turn, that diagnosis is attached to an ICD-10 code, which then may or may not map to one of those HCC codes. And those HCC codes, if it does map to them, there is what they call a RAF score, a risk adjusted factor, and that is calculated every year using those diagnoses, the demographics. So, and then like those combination codes like we talked about with like diabetes and chronic kidney disease or hypertensive heart failure. So, and that's how payers, they use that risk score to predict like the cost of what it's going to take care of, how much it's going to cost to take care of that patient. So for example, this year when we submit all of our codes, they look at that RAF score and say, wow, they have a higher RAF than they did last year. So means I need to give more money in the pot to take care of these patients. Or gosh, their RAF score is lower, so we don't need to give them as much money, or it's about the same. So that's kind of, again, the 100,000 foot level of why and how you do that. The second question, I think was from a provider, I don't know, but just based upon the question, was we don't have a coder in our health center. So how do we make sure that we're doing it correctly? Lots of health centers don't have coders, and that's okay. So, providers, it really comes to you documenting and coding your diagnosis to the highest level of specificity and making sure to capture those combination codes, like we talked about with hypertensive chronic kidney disease and then chronic kidney disease to the highest level of specificity. So, for example, if you're the provider and you're seeing a patient and you're like, I'm just going to pull over chronic kidney disease unspecified, you're going to not get any credit for that RAF score. So you're going to have, between you and your MA, try to figure out what that chronic kidney disease stage is. So even if you had a coder, they can't look at the GFR and assign the stage. That has to come from you as a provider. So it really is driven by provider documentation. And then the last suggestion wasn't the last, but the last one I'm going to talk about was somebody asked, it would be really nice if you had more information in your slides instead of like subjective with nothing under it. So as a speaker, it's a catch-22, right? I give you like all the bullets. Sometimes you don't pay attention, but that was a great point. So for this presentation and the next one, I went and added that additional information. So thank you so much for the feedback. It is very helpful. Okay, so let's get driving on today. We are going to talk about ADHD and asthma, and thinking about best practices for documenting and reporting our diagnosis codes to the highest level of specificity. So the next 4 slides are really going to talk about the meat, the monitoring, the evaluation, the assessment, and the treatment. And you're looking at this and saying, Shelly, you told me you're going to put in more information, but this slide doesn't have any more information. It's because they're all on the next 4. So I separated them out for you guys. So when we start to think about the monitoring, this is really showing the provider is actively tracking and monitoring the condition over time. So obviously the key idea of monitoring equals tracking that condition's status and the impact. So is it getting better? Is it getting worse? How long have you had it? Especially related to the ADHD, what kind of symptoms? Are they inattentive? Are they hyperactive? What are those symptoms that mom or teacher or patient's telling you? Are they having increased difficulty completing their homework? Or are they bouncing all over the room? Obviously, monitoring would be looking at some of those Vanderbilt forms completed by the teacher. So looking at those symptoms. Monitoring medication. So patient, are you taking your medication? Have you had any side effects from that? How's their performance at school and their behavioral incidents since their last visit? So again, we're looking at all of the monitoring of that ADHD related to the documentation. Evaluation. So evaluation is showing where the provider is interpreting the data. Again, so it could come from those Vanderbilt scores, for example, reviewing any kind of results, if there were like lab results, and then assessing how the patient is responding to the treatment. So really, when we're thinking about evaluation, it's really interpreting the findings, not just listing them. So what sometimes providers do, not so much with patients with ADHD, but what they'll do is they'll list a diagnosis or a test, like Vanderbilt was completed by the teacher, but they don't really show their findings like, hey, I reviewed it and this is what I'm seeing. So that's really important on the evaluation side. Again, evaluations can also be related to the medication. What kind of side effects are they having, if any, etc. Assessing. So this part is really showing our providers making a clinical judgment about that patient's ADHD. So what's the status of that? Is it uncontrolled? Is it inattentive? Are they doing well and everything's great? And that not only are they making the clinical judgment, but they're kind of looking at the overall status and severity. So are they not responding to their stimulant dose? Are they having some underlying anxiety related to it? So this is, again, really where we're looking for that provider's proof of thought, their clinical judgment. And then treat. So the last part of the meat, this is showing that the provider's actively managing the condition. So obviously, like the key idea is treating equals like medication changes, referrals, counseling, follow-up visits, homework between now and the next visit. So those are things that we're looking for when we're thinking about the treatment aspect of it. And when we're thinking about the treatment, one thing for providers is really to get in the habit of not only the what, but the why. So ADHD, inattentive, combined, whatever the case may be for the diagnosis, we're going to increase the medication due to the persistent symptoms. Sometimes we'll just see increased medication. We can obviously go read the history and kind of correlate it all, but this really helps kind of solidify the documentation. Okay, so when we're thinking about that, what I would call meat example, monitoring ongoing attentive symptoms and reviewing the teacher feedback, showing continued difficulty staying on task, evaluated the Vanderbilt scores in the growth chart, noting stable weight and partial symptom improvement. Assessment, ADHD remains only partially controlled on current dose. Treatment plan, increase stimulant dose, reinforcing behavioral strategies at home and at school, follow up in 4 weeks. So from a coding perspective, we can code this. I would recommend here just better documentation. Treatment plan includes increasing stimulant dose because patient still has ongoing inattentive symptoms, just to kind of solidify that. One of the things that I do want to tell you as we're kind of going through the ADHD, so with HCC codes, so those are your value-based care codes for Medicare. In version 28, that is the version we're in now. Right now, value-based, there's no value-based score for any of the ADHD codes if you're part of a Medicare ACO. We do know that many other payers that you may have contracts with for value-based care include a score for ADHD. Outside of value-based care, we know it's important always to code to the highest level of specificity. And we also don't know when Medicare may include those ADHD codes, if ever, in another version. So it's always important because, as I told you earlier, outside of value-based care, it's really describing the complexity of the type of patients that you're caring for in your health center. Okay, so let's talk about things to consider. When we're thinking about ADHD, we want to think about the type. So we want to make sure that the type, if we know, is documented to the highest level of specificity. Is it inattentive? Is it hyperactive? Is it combined, etc.? This truly helps describe the type of patient, but it also obviously, as for you as a provider, guides your treatment selections. So making sure when you know, we document it. If you're like, today, I don't know if it's inattentive, hyperactivity, this is the first time I'm seeing this patient, unspecified is okay. It's a payable code. What payers watch for is how long is it unspecified? Again, you're the provider, so you make the ultimate decision, but they start questioning it. Are we just pulling it off the problem list as unspecified because that's what's on my problem list, maybe not really what the patient has? They look for age of onset. So when did these symptoms start? So ADHD is a neurodevelopmental disorder. So DSM-5 requires symptoms to begin in childhood. So this confirms that diagnosis meets that DSM-5 criteria. It also differentiates from ADHD in adulthood. Maybe that patient's had some trauma or anxiety or something like that. So again, helps to tell the story. Severity. So we're looking for the severity of the ADHD because that helps describe how much the diagnosis of ADHD interferes with the patient's functioning, supports that medical necessity for treatment. It may help support frequency if you're seeing a patient more frequently than you would see another ADHD patient. It helps justify any kind of medication adjustments or referrals. So there's a lot of different reasons that we're looking for the severity. The current course, sorry, that is definitely a tongue twister. We know it's chronic. It's not going to go away, but it is variable. So we're looking to see what the current episode is. If it's in remission, is it in partial remission? Is it in full remission? Again, this supports that ongoing monitoring part of the meat, right? It also supports your E&M. If a patient's symptoms are worsening or the medication's not working, they're not at goal, that definitely starts to support a different level of E&M code maybe than when a patient is doing well. So we need to know the course. Manifestations. So examples, what are some of the symptoms impacting that patient's daily social functioning, their education? So are there underlying manifestations that impact this patient's condition. Again, this supports the frequency, the treatment decisions. If you're titrating medications or transitioning to a different medication, it all starts to tell a story for that reader. We know that ADHD commonly co-occurs with other diagnoses such as anxiety, depression, learning disorders, ODD, sleep disorders. So comorbidities can increase the risk. It increases the complexity for providers. So it helps, again, identify that proof of thought. What are you as a provider thinking about when you're taking care of this patient with ADHD? So if we had a group of providers and we said, gosh, we've got this patient with ADHD, they have no manifestations, they're doing great, they have no underlying comorbidities, but we've got this other patient over here, they're the ADHD is affecting their work schedule, their life with their, family members. They also have underlying learning disorders and anxiety. Which patient is harder to take care of? Your provider is going to say all day that one with those underlying conditions and comorbidities. So it does help really describe and tell that story. So DSM-5 alignment, documenting the criteria again, just shows that you're following that DSM criteria. It protects against audit denials. It demonstrates that the diagnosis is clinically justified. And of course, it supports that long-term treatment planning for that patient. It has an impact on functioning. So when we're thinking about school performance or productivity at work, relationships, daily routines. So it really starts to connect those symptoms that the patient's having really to the real world impairment. It supports counseling, of course, your medication decisions, anything like that. Status. Is it active? Is it in remission? So again, that starts to help tell the story and the complexity of that patient. And then when we're thinking about medication and treatment response, we need to know, is the game plan to continue the Vyvanse as directed because they're doing well? Is the game plan to increase the Vyvanse, change it to a different medication, and why? So again, we want to know not only the what, i.e. your diagnosis, but the why, because it's telling a story for that reader. We don't know your patients, so you have to document how your patients are doing, the symptoms they're having, how they're responding to the treatment. And you as a provider, I don't know your proof of thought, right? I'm not a physician. I'm not a nurse practitioner. I'm not a PA. I'm a nurse. So I don't know your proof of thought unless you document it. Same for the payers. So the supporting documentation when we're looking at ADHD, obviously these aren't going to be in every single note, but in different notes throughout. Could be rating scales filled out by the parents or the teachers or others. There could be job performance evaluation. There could be third-party interviews. There might be historical information, maybe from like academic transcripts or teacher comments. Maybe there's evaluations from like a tutor or report cards. So any kind of supporting documentation is helpful in kind of telling your story. Remember, the clinical documentation must clearly differentiate like ADHD from different types of disorders. So from hyperkinesia, I never can say that right, sorry, conduct disorders, or is it really truly just simple disruptions or disturbances from activity and attention? So again, this is why we rely on really good documentation from our providers. So when we start thinking about just kind of in summary, we're looking at that assessment, that clinical assessment. So clinical assessment today indicates persistent symptoms consistent with ADHD combined. The patient demonstrates ongoing inattention, difficulty staying focused, forgetfulness, they're disorganized, hyperactive impulsive behaviors, restlessness, interrupting. Symptoms occur across home and work settings. They've been present since childhood. Their current presentation reflects partial response to medication with continued functional impairment in task completion and time management. No evidence of mood instability, psychosis, or substance misuse contributing to the symptoms. So, what this shows is providers' clinical judgment, symptom pattern. It shows the current status on treatment, and it starts to rule out other causes. With the history, they begin in elementary school, long-standing difficulty sitting still, completing assignments and following multi-step directions was hard for them. Family history significant for ADHD. Patient reports prior behavioral therapy in adolescence and stimulant treatment during college, had good response. No head injuries, no seizures, no developmental delays. Symptoms have persisted into adulthood and continued to interfere with daily functioning. So, with the history, this starts to tell the story of age of onset, kind of what the developmental course has been, some family history, prior treatment. It outlines that chronic condition across the board. When we move into functional impairment, ADHD symptoms significantly impacting functioning at work. The patient misses deadlines, struggles with organization. They require frequent reminders from supervisors at home, difficulty managing bills, routines, completing household tasks. The patient partner reports patients forgetful. They have impulse decision making, increased stress, reduced productivity, strains on their relationship. So, what this shows us from this documentation is that real world impairment. It's also showing you that it's impacting multiple settings, right? Work, home. It's starting to support my medical necessity for treatments or for frequency. And then what are the other diagnoses that are being considered? So differential diagnosis considered and ruled out conditions that may mimic ADHD, anxiety, and depression screenings were negative, reducing the likelihood of mood-related concentration and issues. No evidence of thyroid dysfunction, sleep apnea, or medication side effects contributing to the symptoms. Cognitive impairment due to learning disabilities was considered. These symptoms are consistent with lifelong ADHD rather than isolated academic deficits. Substance use was screened and is not contributing to the current presentation. So, what does this show us? It's showing us the provider's proof of thought. What else did they consider? What are the other causes that may be going on? So again, this provider's telling me like, hey, I did all this work. This is what I'm thinking about. It tells us the symptoms aren't better explained by another disorder or condition. It supports that diagnosis accuracy of the ADHD. And of course, overall, it's going to strengthen my audit proof documentation. So when we're looking at ADHD, as I said, we always want to document to the highest level of specificity. The DSM-5 guide provides clinical criteria for diagnosing ADHD. Again, I'm not a provider, but I know like some information that I like looked at indicate like if children have 6 or more symptoms of this, the diagnosis of the disorder present, age kind of plays a part. Did the symptoms begin before 12 or 17 or older? So again, providers just making sure that they're using that criteria appropriately to diagnose to the highest level of specificity. And so with the highest level of specificity, if we know it's inattentive, so difficulty with organization, paying attention, or is it more hyperactivity, impulsive, so they're distracted easily, inability to focus? Or is it kind of a combination of both? So I'm having symptoms of both. I'm having trouble paying attention organization, but also I'm very easily distracted. So again, it might be the combined type of ADHD. When our provider has a suspicion the patient has ADHD, but not yet diagnosed, we would want our providers to code this R code. All of the R codes are signs and symptoms. So this will not tag a patient with a diagnosis they don't have. In the clinical world, if our provider says, gosh, I think Shelly has ADHD, but I'm not really sure yet, I got to do some testing, but I'm going to go ahead and report ADHD unspecified. That goes out on the claim form. You have now just tagged me with ADHD. I can never get it off my record. Even if you come back to your billing team and say, gosh, billers, I made a mistake. She doesn't really have that. So let's go back and your billers say, hey, there's a great code out there. Attention and concentration deficit. Let's fix it to that. You correct the claim. I still have it on my account. It will never ever go away. It's correcting that one claim, but it's already went into like what I would call the viral system where it's all over saying Shelly has ADHD. So if we don't know, always go back to those signs and symptoms. And if you're not sure, even if you don't have a coder in like house or on staff, ask your billing team. They are really good and they will know where to look, at least to either reach out to somebody like me that does consulting, or they could reach out to like Terry and she might have a resource, or they obviously have other resources in other health centers they can reach out to. Okay, so subjective. This is that patient's story. So I'm looking for how the patient's doing. So it depends on who is taking the patient's story, provider or clinical staff, and it depends on what they're asking. So we might see something like patient presents today with mom. The mom indicates patient's easily distracted. He has trouble remembering to complete and turn in his homework. He doesn't do his chores like he's supposed to. The mom states he doesn't support any signs of anxiety or depression that she can tell. So again, this is kind of the patient's story, taking their meds. How are they feeling? What signs and symptoms are going on? How does mom or dad perceive you? How do teachers perceive you? That kind of stuff. The objective, this is where I'm looking for the provider to do either a physical exam, mental status exam. Some providers do put their assessment results in here. There's no magic spot you have to put them, but some do. So you might see something like Vanderbilt's ADHD scale was reviewed, showing 7 inattentive symptoms. The notes from the school provided by the mom showed this, that, or the other. There might be a mental status about the patient's general appearance. You know, they were bouncing all over the room, stuff like that. The assessment. So this is my provider story. What is the final diagnosis? You've taken those subjective, the patient story, you've taken kind of your assessment, your objective portion, and now what are you coming up with? I'm either coming up with a final diagnosis of some sort, or I'm coming up with those signs and symptoms. So, and then are there differentials you're thinking about? Are there underlying comorbidities or conditions? So I might see ADHD, predominantly inattentive type moderate. I might see, I don't know, so attention and deficit concern, rule out ADHD, or rule out anxiety, things like that. And then the plan. This is where I'm looking for, what did we tell the patient to do? Start a medication, continue a medication, stop a medication. Are we referring them somewhere else? What are they supposed to do, like homework between now and the next visit? So we might see continue XYZ medication as directed, referral sent to behavioral health therapy or behavioral therapy for family coaching. Patient will follow up in 4 weeks for ADHD. So let's look at an example for an adult. So chief complaint, difficulty staying focused at work and feeling restless. So the HPI, again, remember, is the patient's story. So they're having difficulty staying focused. They have ongoing symptoms of inattention, forgetfulness, impulsivity, so difficulty waiting their turn, interrupting people. They've had this since childhood. They continue to impact their performance at work, no substance abuse, occasional anxiety, um, medications that they're on, psychosocial, they live with their spouse, they're employed, review of systems when pertinent. So this one, no chest pain, palpitations, mood disturbances, but mild insomnia when taking their evening dose of medication. And then my objective portion. So this is what the provider deems is clinically relevant for today's visit. General appearance, their mood, their thought process, their concentration, their judgment or insight, physical exam, vitals, if relevant, taken maybe by the clinical team, any kind of screening scales that were performed, final assessment and plan. ADHD combined, moderate severity, ongoing symptoms of inattention, hyperactivity, etc. Comorbidities include mild generalized anxiety disorder, stable, currently no medication. And then they're tolerating the stimulant therapy with mild appetite suppression, also having some intermittent insomnia. Remember, because they said at the evening dose it was causing some insomnia. And then we kind of want to finalize the plan. Medication, you're going to continue this medication. Advice to avoid late evening dosing to reduce some insomnia. Monitor their appetite and weight for the next visit. Behavioral interventions, we want them to continue their CBT-based coaching. We want them to think about stress reduction techniques for their anxiety. And then what are we going to do for follow-up? We want them to be assessed again by us in 1 month for the ADHD symptom control and side effects. We want them to repeat their screenings. We want to monitor their heart rate, blood pressure, and sleep patterns. And then what kind of education did we give them? We talked to them about adherence to their medication, side effects, the importance of follow-up, and to notify the provider if there's any kind of worsening symptoms related to their insomnia. Now, if we look at a child one, it's going to be a little different, but we're going to solve the same components. Chief complaint, ADHD follow-up. What's going on with that patient? He was with mom. He's taking his meds daily, struggling with math. He understands the material, just not getting it completed and turned in. No side effects. He's sleeping well at night. No summer school last year. Recommend a meeting with the teacher to discuss summer school options for this year. And then review of systems when applicable. So again, this is all my patient story. And then I'm going to go to my exam. So this is what my provider thinks is clinically relevant. So constitutional, no acute distress, they're well developed. Provider's also going to do eyes, ears, nose, and throat on this patient, lungs, cardiovascular, and then mental status portion, oriented time, place, and person, behavior is appropriate, no normal attention span, no suicidal ideations. And then I get to my provider. So now my provider's taken the patient's story, their exam, and they're coming up with their final diagnosis or signs or symptoms. ADHD, inattentive type, increase the medication. So I like them to state to help with control the symptoms, just kind of telling the why you're increasing the medication. And then what's the game plan? So for this patient, the provider says, come back in 3 months. So we don't know, based upon this note, if our provider has asked them to really try hard to set a schedule to get their homework in on time, make a calendar, put deadlines on it. So whatever happened, we want to know. On this, it looks like the provider just said, hey, we're going to increase your medicine and I'll see you back in 3 months. It doesn't look like there's any homework. Now, if we were behind this provider, there may have been homework. So again, we want to make sure the provider documents that detail. We want to start thinking from our provider perspective, from a documentation and coding about some of those comorbidities. Conduct problems, anxiety, depression, learning disabilities, ODD, neurodevelopmental disorders. So any of those underlying comorbidities that impact decision making or risk, we want to make sure those are connected. So when we think about just important tips for documenting and coding, be specific. If you only know ADHD unspecified, then that's what you would code. But once you know the severity, status, and type, make sure it's clear. Make sure you link any of those underlying conditions so that we know what those underlying conditions or comorbidities are. Describe the impact, like their daily functioning. How are they adhering to their medications? Are they having any side effects or risk? On the behavioral interventions, are they going to counseling? Are they skipping counseling? Is there parent training in place? And then, of course, update at each visit. Are the patient's symptoms better than last time? Worse than last time? Different than last time? What's been going on since the last visit? From a coding perspective, and I know providers, you are not looking at that ICD-10 book, and I'm totally okay with that. Billers, coders, if you get denials related to diagnosis, a couple of things you want to look at. If you look and you're like, well, those are real diagnoses, those are all appropriate, all documented. Look to see if there's any excludes notes. Excludes two means we can report both of these diagnosis codes as long as they are like both kind of separate. So mood, ADHD together is fine as long as they're separate. If you see any that say an excludes one note, doesn't matter, means you never ever can report those codes together. So like a good one that I can think of off the top of my head is bipolar disorder and depression has an excludes one note saying you can never ever, no matter what, we don't care how great the documentation is, you can never report those two codes together. There's a bipolar with depression. If that's what the provider wants them to have, they should document that and we would code that diagnosis. Otherwise, we just remove the depression and only code the bipolar. Okay. So when we're thinking of best practice, ADHD combined moderate severity with comorbidities of general anxiety disorder. Symptoms interfere with work productivity, family relationships, on stimulant therapy with good response, occasional insomnia side effects, will continue XYZ medication as directed. A poor practice, ADHD on meds stable. I don't know the specificity of the ADHD. I don't know if they have any symptoms. I don't know if the med's working or not. I don't even know what med. So again, I don't know, should they continue the meds? They're on them, but do you want them when they leave here to continue? So this is a poor practice of documentation. All right, so what are some common mistakes? ADHD unspecified is kind of on the problem list and reported too long. This code is kind of what I would call like a placeholder. I'm holding this until I get a more specific diagnosis. Common mistakes, we don't update the problem list. So we keep pulling over the same unspecified diagnosis. Comorbidities, they're not included when they should be. It doesn't, we might read it in the history, but it's not pulled into the assessment plan. And then of course, one other one I forgot about is bringing forward previous notes without updating the symptoms. So sometimes providers bring forward the previous note, but they don't update for today's visit. So it's identical to the previous visit. So let's talk about workflow for ADHD. MAs, make sure you're reviewing the problem list. Are there more than one ADHD diagnosis code? So if so, we're going to talk about that during our huddle so the provider can update it. If it's still unspecified, we're going to talk about that during the huddle. If it's a new evaluation, do you have a referring provider note that the provider can reference? Are there any assessments like the Vanderbilt, or is there an ADHD self-reported scale? Do we need any screenings at today's visit? So PHQ, SCARE, GAD-7. When was their last stimulant refilled? And are you the one checking the PDMP? And again, that's state specific, so make sure if the MAs are going to do that, that they can do it in their state. Some states only allow licensed clinicians, and I don't know off the top of my head for Kansas, so that would be something you'd want to check. But that's all going to be part of my pre-visit planning, whether it's the MA or the provider. Both should be pre-visit planning together. And then we come together at our huddle and talk about it. What can your EMR do? Consider embedding the scores from those testings into the progress note. Display like any kind of trends in graph form for our providers to look at. Maybe we insert a structured summary in the assessment plan. Can it help pull in the last stimulant refill date? If the PDMP is integrated, have the summary pull in. And are there any prompts like type, severity, functional impairment, comorbidities, medication response? So again, just making sure that it all correlates together. So using our clinical providers, our clinical staff and providers, as well as our EMR to help with that workflow for ADHD. Okay, asthma. Again, we're going to see the same thing we talked about with ADHD. We've got to show the meat. So the meat is kind of really what I would call like that active management. Monitoring frequency of wheezing, nighttime awakening. So telling that story. So looking at medication, what are those signs and symptoms? Sometimes monitoring is looking at recent test results. Asking about contributing factors. Maybe they're a smoker or they're around smoke exposure to. So all of that. So when we're thinking about monitoring, again, what it shows is we're tracking symptoms, triggering, frequency, all of that. Evaluation. So evaluating the asthma control, you might have an ACT that was done that day. You might be reviewing previous PFTs or spirometry. You might be evaluating based upon the inhaled steroid. So this is where providers are interpreting objective data, not just listing it, but truly interpreting or reviewing the report. It's also where our providers might be doing part of the exam. What are they seeing? What are they hearing on the respiratory? Assessment, again, this is where I'm looking for that final diagnosis to the highest level of specificity, signs and symptoms if I don't have a diagnosis yet defined. We might have underlying conditions in here. So if they are a smoker or they have an exposure to smoke. So really this is kind of my provider's like proof of thought for the conclusion about the diagnosis, the severity, the stability, the underlying contributing factors. And then my treatment, increase their inhaled steroid dose, added a long-acting bronchodilator due to poor control, provided the ACT, given them an action plan, all of that. So what our treatment shows is medication changes or continue the same, education for the patient, an asthma action plan, when should they follow up, is there any referrals between now and the next visit? So again, that all falls under my treatment plan. So what do we have to consider with asthma? Severity. So this is where I didn't put things under this one, guys, just because it's pretty evident based upon what the title is. This is we're looking for the severity of the patient's asthma. Is it mild? Is it moderate? Is it severe? So again, the severity. Do I know the cause of their asthma? For example, is it exercise induced? Is it related to smoking? Is it related to chemicals? So what's the cause? Are there other conditions that the patient is experiencing? Maybe they have an infection. Do they have an exacerbation? I also want to know kind of about exposure, like tobacco, occupational exposure. That helps, again, tell that story. What kind of documentation tools? Did we utilize the asthma action plan or other documentation tools to either assist with the continuity of care or treatment adherence. So you're teaching them how to use the inhaler. And then what is the follow-up? So do they need to limit activities at school or sports? Are they going to continue the same medicine? Or are you going to change a medicine? Again, what's the game plan for between now and the follow-up visit? I want to know risk factors. So do they have allergies, respiratory infections, obesity, GERD? All of that would be like medical risk factors. Environmental, we kind of talked about those a lot already. So like exposures to smoke or occupational exposures. Sometimes it's just the cold, dry air is a risk factor for that patient with asthma. Family history, again, smoking, all of that would be part of the personal behavioral and history. In this subjective, again, this is that patient story. I'm looking for like when that patient comes in, what do you want to know? Are you taking your meds? What symptoms have you had since last visit? Tell me about those symptoms. So again, I might see patient here today to follow up on asthma. They've had an increased shortness of breath due to the change with the allergies, some chest tightness. I might have patients here today to follow up on asthma. They're doing great. Everything's wonderful, taking their meds as prescribed. And then the objective, this is where my provider is going to do their exam. Also, this may be where they put any kind of scores, so the ACT, etc. And then what's my final diagnosis? If I don't have one, I'm going to use my signs and symptoms. I'm going to include some differential diagnosis. If I have my diagnosis of asthma, I want my provider to document to the highest level of specificity. Mild, moderate, severe. Is it intermittent? Is it persistent? Do they have a history of a condition that impacts their asthma? That means that I had a condition, it's cleared up, but it still is always in the back of your head. And then the plan. Continue the same medicines, change a medicine, increase a medication. When should they follow back up? Are you referring them to anybody? What should they do between now and the next visit? Should they, decrease their sports time or outside time? So kind of what I would call like a checklist for asthma. Reason for visit. Why is that patient coming in? Let's have a checklist that's showing that we need to review those symptoms, those daytime symptoms, nighttime symptoms, activity limitation, how they're using their rescue inhaler. Are they having any exacerbations? Have they been to the hospital, the urgent care, or the ER? Have they noticed anything that triggers their asthma? Smoke, weather, viral illness, maybe that they've had. Their current medications. I want to know what you're taking, how often you're taking them. Do you take them correctly? Are they working? And then I move to my provider part of my checklist. So the physical exam. Provider, obviously the staff will be doing my vital signs, but then my provider might do, again, it's clinically relevant, whatever the provider determines. So this provider may say, gosh, for Shelly, I just need general appearance, lungs, and maybe they have the ACT or something they want to put in there. It's totally up to the provider what clinical exam they feel is relevant for that patient. And then, of course, I need a diagnosis. So asthma, and then I want to know the severity to the highest level I know today. Are there other diagnoses that impacted your decision making or the risk of the patient or something just like in the back of your head you're thinking about? And then what is the plan? Continue XYZ medication, increase XYZ, only use your inhaler, your rescue inhaler when this happens. Do a NEB treatment when this happens. Maybe you're updating the asthma action plan. Talk about trigger avoidance. When should they follow up and why? So I might have a progress note. The 8-year-old comes in had an exacerbation of her asthma on vacation, a lot of secondhand smoke. They used the albuterol again this morning, a little over an hour before they came. It doesn't help. The dad and brother also have asthma. We have our pertinent exam. So on respiratory, we do show that there's some diminished breath sounds, some wheezing. And then our final assessment plan, intermittent asthma with acute exacerbation and why. It's caused by secondhand smoke. Neb treatment given, improvement of the 3-day course of the oral prednisone, or with improvement, and then started them, on a 3-day course of oral prednisone. They do have a family history of asthma. And then on my next patient, this patient comes in and they're a little bit older. They're 15. They're having this shortness of breath and coughing. They have a history of severe persistent asthma. So kind of going through the whole history, what's been going on, but there's not been any ER visits since the last exacerbation. But they did complete a 5-day course of steroids back in September, past medical history. And then of course my medications that the patient's on, any kind of allergies, and pertinent review of systems. Again, this is what you deem clinically relevant for this specific patient. Then my provider documents their exam. Again, this is what the provider determines is pertinent at this visit. Obviously, on an asthma patient, we're always going to look for a respiratory, no matter what. And then our final assessment. So this provider did a great job. Severe persistent as that asthma with exacerbation, frequent nighttime symptoms, worsening control despite their high dose of the steroids, and it's triggered by seasonal and exercise. So I've got a good diagnosis. Now, what's my plan? We're going to administer albuterol in the office. We're going to start prednisone. We're going to continue the medications that they're on. We talked about the asthma action plan. We reviewed the yellow, green, and red zones and when to seek emergency care. We reinforced the spaced device and the inhaler technique. We provided school asthma form for the rescue inhaler, and especially during sports. And we told them we want to see him back in 1 week or sooner if symptoms worsen. So we can really determine the severity of this patient as well as what the plan of care is and what they're supposed to do between now and the next visit. So we talked about the provider's thought process. If you're not well controlled at the next visit, we're going to consider a referral to pulmonology. And then what kind of education we provided for that patient. So a best practice, severe persistent as asthma with exacerbation, and then including those test results and then those underlying symptoms and using albuterol daily. That's poor practice, asthma flare requiring neb treatment. So we always want to document to the highest level of specificity, always. We also want to include any of those underlying conditions, obesity, GERD, nicotine dependence. We want to know what treatments the patient's on. We also want to think about those underlying codes that we might miss, like long-term current use of inhaled steroids or systemic steroids. There's a Z code for that that can go with my asthma diagnosis. When asthma intersects with bronchitis or COPD, it directs us to use this ICD-10 code. There is an instructional note that tells us to use an additional code to describe the type of asthma or asthma exacerbation. Do not assign unspecified asthma. So J4909, it says don't use that. So we want to have a more specific. You can see J4909 is uncomplicated, unspecified. Now, we talked about in the ADHD, those excludes. Asthma does have an excludes one that says you may not report wheezing and asthma together. Those go hand in hand and they are completely related. So if you report both of these and you get a denial, that means that you should not have reported the wheezing. So workflow, when we're thinking about pre-visit planning, is there a self-assessment form completed by that patient or other things like a Vanderbilt that you should have? Review your problem list. Do I have multiple asthma diagnosis codes? And if so, is there an unspecified on there? Do we need to talk to the provider to remind them to pull the most specific? Is there only unspecified on there? And if so, do we need to remind the provider if that's accurate? Great. If not, let's update it. We want to review the medication list. Is there a controller medication? Is there a rescue inhaler? Are there any duplicate or outdated inhalers? And again, when we're thinking about pre-visit planning, remember this is your clinical staff and your providers. We want to review the social history. Oh, does it show smoking? I want to verify that. Does it show a non-smoker? I want to verify that. Any allergies, pets, mold, dust, seasonal, food. When was their last ACT score or other control assessment? And when was that completed? When was their last PFT or spirometry results? And what were they and when was the date? Do they have any urgent care or ED recent visits? And then are there any barriers? So cost, no insurance, hard to get transportation, all of those things we're thinking about. So we both pre-visit plan, the provider and the clinical staff, we come together and we talk about it. So why is the patient coming in? Is it a follow-up? Is it because they had an exacerbation? They were seen somewhere else? Why are they here? Providers, direct your clinical staff what questions you want asked before you walk in the door. What do you want ready? If you don't direct, they don't know. And then, of course, if it's acute care, things we might direct the clinical staff is how long did they have the symptoms? When did they start? What triggered it? Do they have fever? Do they have sputum? Any other upper respiratory symptoms? How are they taking the medications? Are they using the rescue inhaler? How often? Follow-up care. We want to talk about follow-up care. Are they taking the medications? Do they understand how to use the rescue inhaler? Do we need to teach them? And then any kind of key findings from the planning. So, oh gosh, here's the latest ED visit, or here's the last ACT score and date. Here's the last spirometry. And then we come to room the patient. So again, this goes back to my clinical staff. So go through those symptoms, go through the triggers. Go through, are you taking your medications? Do you know how to take them? Are you taking them correctly? Do you miss doses? How often? On that rescue inhaler, tell me, have you used it? How often do you use it? When do you use it? Does the asthma wake you up? Any kind of steroid use recently? When was the last one, if you remember? Have you been in the ER or the urgent care? Have you been seen by anybody for your asthma since the last visit of, October? Are you having other signs and symptoms related to your asthma? Chest tightness, shortness of breath, wheezing, gasping for air. And then peak flow if the patient uses one. And then, of course, any exposures like smoke, allergies from the trees changing, pets, etc. And then what can our EMR do? Build templates with drop-down boxes for severity. Auto pull in some of that last ACT score and the date, last spirometry and PFT, last steroid burst. Anything that we can help that gives the provider the information they need. Can we embed and auto score that ACT? Can we trend like over time, graph it out? And then can we insert a summary into the note with one click based upon some of these things that the provider's wanting to look at? So we've got pre-visit planning, we've got huddling, and then you've got EMR, all related to the workflow. Okay, guys, I know that was a lot of information in a really short amount of time. So what questions, thoughts, comments? I hope this was more helpful, putting some more detail under each of those so that when you take them back, you have that without having to listen to the whole webinar over again, if you're trying to find one thing.
Well, feel free to take yourself off mute or just type a question into chat. There aren't any questions right now in chat, but
Perfect. So while you're thinking, and again, like Terry said, please just come off mute. It's easy. We're a small group. Please fill out the evaluation, you guys. That really helps not only Terry, but it helps me as a speaker. when I'm giving the information, it's much different than when you're receiving the information. So that those comments do help. And as well as if you're thinking about other things that you think about your team would really like more education on, that also helps Terry to know, like, gosh, I'm seeing, like 10 people asking for E&M education or more information on XYZ diagnoses. She will be able to determine then, golly gee, if a lot of people are asking for this, maybe this is something we need to do. So questions, comments, thoughts, or if you have like a really good process in your health center that you're already doing that you want to share, your team would love to hear that. So please feel free. And if you don't have questions, I know it's straight up 1 o'clock and I know you guys are all busy. So feel free to jump off if you are done. I'll stay on a little bit in case you do have questions.